Welcome to the Clinical Pre-Hospital Care Research Forum Journal Club. Here in our PCRF Journal Club, we promote evidence-based practices by critically evaluating the latest science in emergency medical services. We hope our discussion will help advance EMS practice. Through the generous support of our sponsors, Limmer Education and ESO, we are able to make science more accessible and understandable.
All right, welcome everyone to November 2025 edition of the Pre-Hospital Care Research Forum Journal Club. Hard to believe, second to last of the year. Special thank you again to our sponsors, Limmer Education and ESO, for making it possible for us to be gathered here today. I'm Remley Crow. Today I'll be joined by Dr. Tony Fernandez, Jeff Rollman, Michael Caduce, and Dr. Bill Toon. And we are very lucky, excited to have with us special guest editor, Dr. John Ling. And I say that because the name of the articles we are reviewing, this is not a typical podcast, but we're actually going to look at the National Association of EMS Physicians Compendium of Pre-Hospital Trauma Management Position Statements and Resource Documents. Wow. Quite a mouthful, but this is the NAEMSP Trauma Compendium, as it's known. It's publishing live in pre-hospital emergency care, still a couple of pending, and we'll talk about that. But in this episode, we're going to do things a little differently. So we'll talk through what the Trauma Compendium is, why this matters to you, some key take-homes and guidance for pre-hospital clinicians and system leaders. We'll talk data, of course, research gaps, and we'll talk about how we might integrate these insights into our workflows, triage, pre-hospital decision-making. But first, this discussion, as always, is paired with an article written by our very own columnist, Michael Caduce, in EMS World called Journal Watch. I encourage all of you to check it out. It'll be on emsworld.com under the category of education and training. And I want to thank those of you who are here with us live today. As we begin, I want to remind you that you can use the chat feature on your screen to type in questions and comments, and we can bring those into the conversation as we go. And so without further ado, we've got a full agenda, so I'll kick us right off. First, I'd like to welcome Dr. John Ling. Thank you for joining us. And perhaps you can give a little introduction about who you are, and I'm very curious about how you got interested in EMS research.
Sure. Yeah, I'm glad to be here. Thanks for having me. So who am I? Well, I'm an EMS and emergency physician practicing in Minneapolis, Minnesota. I got my start in EMS literally as an ambulance driver, CPR and first aid certified in my hometown, and started driving the ambulance, and within a few months recognized, hey, I kind of am interested in what's going on in the back of the truck too. So got my EMT basic from the National Registry back in 1997 and never looked back from there. Kind of worked my way up through all the different roles and ranks, up to being board certified in EMS medicine. So why did I get interested in EMS research? Well, I am honored that you consider me as an EMS researcher, because I think, excuse me, a lot of the times when I think of research, I think of somebody who's doing the bench studies or the initial studies that everybody else then reads, like all the stuff that I had to read through and that the rest of my team had to read through in order to build the trauma compendium. So in that sense, I guess looking back at what everybody else has done before you is really an important part of research, because one paper tells you one thing, many papers tell you multiple things, and sometimes either reinforces the message or tells you that there's mixed results and a lot of uncertainty. And I think that's to me some of the take-home messages from this compendium was uncertainty is very prevalent in our field because it's so young. We've really only been doing EMS medicine since the mid 1970s, when it became, an official kind of recognized aspect of first response and emergency care in the field.
That certainly resonates for me as well. I think every time I publish a study, I raise more questions than I feel like I've answered. So the more questions, the better. And I think we will dive into, there's certainly areas where there is not a lot of evidence, and it's really important for frontline EMS clinicians to participate in EMS research so that we have that lived experience as part of these. But I know that the listeners are anxious to hear what in the world is a trauma compendium. So let's go ahead and set the stage. Let's talk about what prompted this project within NAEMSP, the Trauma Compendium. There was a predecessor to this, the Airway Compendium in 2022, and perhaps you can talk a little bit about how that came to be.
Yes, for sure. So, I guess a little small part of my background too is in the past, I was the chair of the NAEMSP Standards and Practices Committee. And I've been a member of that committee for, I don't know, going on 15, 20 years now. Um, and that committee is tasked by the board of directors and the association membership to identify topic areas that are important to provide clinical or operational or professional guidance on what we think a best practice is. It's not always and often not like an evidence-based guideline because that takes a lot of work to do, and not everything even has the evidence available to even approach it as an evidence-based guideline type project. Um, so over the years, we've written on all kinds of different topics. I mean, if you can think of something in EMS, we've written on it, including, public access defibrillation. Like that's a normal thing now, but 20 years ago, that was something that needed some professional support to promote. Um, so we had written a lot of different things over time about airway management in EMS. And Henry Wang, who I'm sure you've probably had on this podcast, and I'm sure many of you have read a lot of his work, um, talked with us on the Standards and Practices Committee and the board and thought, there's a lot of things that we've written about airway management. Some of it's getting a little stale. We need to freshen up some of it because we've got more research and newer evidence. Maybe we should condense all of this into one focused effort and do a bunch of papers about all the different aspects of airway management. So we had one on manual ventilation, one on mechanical ventilation, supraglottic airways, endotracheal intubation, rapid sequence, or delayed sequence, medically assisted airway management, all of those different pieces that go into managing patients' airways, including education, including quality management, and wrote a bunch of papers on that. So I was very pleased to be part of the editorial board on that project and was a primary author in a few of the papers. And that whole project seemed to be met with pretty good success. And after finishing that project, I was at the National EMS Physician Conference and talking with some of the other leaders and said, hey, you know what? Seems like this was really well received at this meeting. Maybe what should we do next? Should we do trauma next? And they said, sure, why don't you take the lead on that? So within within a few weeks, all of a sudden, I found myself as the editor in chief of a 18 paper compendium, which has been this really really heavy lift.
It is absolutely a ton of work. And you prompted me as we're talking about NAEMSP and the standards and practices and all of this. The P in NAEMSP does say physicians, but I want to highlight that about a third of the members are professional members like myself. And it's a really great place to get involved and to get involved with projects like this, actually. So while it was an incredibly heavy lift for the lead editor, this doesn't happen alone. Can you talk a little bit about the team that you put together for this and the
For
different
sure.
roles that there were?
Yeah, so that's a great question, a really great point. So although yes, we are the National Association of EMS Physicians, this project involved everybody from soup to nuts. So um, any type of EMS clinician, what EMRs, EMTs, advanced EMTs, paramedics, ground and flight crews, EMS physicians that are practicing in the field. I know sometimes people think that their medical directors are just stuck in the office, but a lot of us actually do have active field practice. So we're able to think about and apply what we're doing there and translate that to what we're doing when we're researching and try to make sure that it's realistic for what's happening for the people who have boots on the ground. And we involve people from other specialties, emergency medicine, pediatrics, trauma surgery, excuse me, orthopedics, um, pharmacology. We really tried to make sure that We had diverse representation in terms of the clinician types that were helping provide guidance, um, making sure that people were looking through this through the lens of what's happening in the pre-hospital setting, because what we do in the pre-hospital setting is different from what's happening in the hospital. So we needed to make sure that people had the right perspective on the questions that we were asking and the answers we were looking for. And I think we had over 100, probably 125 contributing authors that were involved with this whole effort. And it was really, many hands make small work. So um, with the whole group, I think so far we've reviewed over 15,000 individual published papers, or screened that much, down to about 1,500 of those are currently in the total, collaborative evidence library that we use to build the evidence on, that guides the different recommendations that we've made in these different papers.
Wow. And even with many hands, there's nothing small about this amount of work. And it's really incredible to see how it's already being received and already changing the way that we think about pre-hospital trauma management. I want to talk first about not only did you have diversity in the team, but in some of these documents, which we'll talk about, some resulted in position statements and some did not. But a lot of these position statements involved other organizations. So going beyond NAEMSP organizations that we interact with. And I want to hear a little bit about your experience in involving those organizations. Why was it important that you went out and did this? And what were the results?
Sure. Well, the low-hanging fruit on some of that collaborative work was it was topics or papers that we had previously collaborated with other organizations on, like traumatic out-of-hospital circulatory arrest is an example. This is probably I think maybe the third or fourth iteration of guidance that's been provided on that. And in the past, I think the American College of Surgeons Committee on Trauma might have been the lead organization. Um, and this time around, NAEMSP was the lead organization. So any of those works that were previously collaborative works, it was a no-brainer. We should invite the other organizations back into the fold, and work on updating this. Excuse me, because it's really important to have diverse investment from all the different stakeholders that our pre-hospital care impacts. So we wanted to make sure that the voice of those other organizations could be heard through these documents as the mouthpiece. And we wanted to speak with a collaborative and collective voice. So it's not helpful if you have 3 or 4 different organizations that put out 3 or 4 different position statements on things that are slightly different or potentially even in conflict, because then you've got medical directors and pre-hospital clinicians who are thinking, well, this alphabet soup over here said to do this alphabet soup over here said to do this, and this other alphabet soup said, we're not really sure what to do. So that type of guidance is not very helpful and sometimes even harmful to advancing the care that we provide.
Right. It takes a village and it takes that collaboration, especially with bigger changes. You don't want to show up unannounced with a new way of doing things and not have others who are also committed to that change and on board, so to speak. Now, we mentioned position statement a couple of times, but these documents generally follow a 2-part structure. Most are position statements plus resource documents. So perhaps you can tell us a little bit about what is a position statement, what is a resource document?
Yeah. So this has evolved over time. In the past, NEMSP would sometimes put together a position statement, which was a very brief introduction, and then some 6 to 7 or so bulleted items or bulleted recommendations, and that would get published by itself. Often with very little or no supporting evidence. We might have had evidence that we reviewed, but we didn't make any citations in terms of anything to support what we're saying. We just said it and said, go forth and do this. In the past, sometimes we would write a whole resource document where we offered up how we collected and how we digested the evidence that supports the bullets in the position statement. And sometimes those would get published separately from the position statement, sometimes not even in the same journal. So we recognized with starting with the airway compendium, that it was really important to marry those two documents together. So now when you find NAEMSP position statements, you'll find this, the first part is the brief introduction. Why is this important? You know, what was the goal of the project? And then it's kind of the Cliff's Notes. It's what are the most important things that we want people to know, and what are the things that we want people to use to guide their practice or change what we're doing. And then when you get to the resource document, you'll see most of the time our format is we take each one of the bullets from the position statement, list the bullet out again, and then follow it with the how we reviewed the evidence, how we digested it, and evidence tables, and the discussion part of our rationale behind what supports the bullet statement that we have.
Yeah, I think this is such a helpful structure, especially as, somebody goes to a conference, hears about a new thing, but then how do you bring that home? Well, these documents have it all in one place so that if we're trying to get our service to evaluate the evidence or consider a change, having it all in one place with those citations and that peer reviewed literature is majorly important. And not only that, the position statements go through a rigorous review process. It's not just a couple of folks sitting in a room saying, these are the things I think we should do. It goes through critical review both at the board of directors and through a peer review process at the journal. So these are, again, really rigorously developed synthesis of what evidence we do have, but they're often in areas where there just isn't a ton of literature out there. And we're going to dive into the different statements. So ultimately, there will be 18 papers, and that, again, is no small lift. This is a huge testament to the leadership of Dr. Ling here. But these are the ones that are published. I'm putting up on the screen just as an example. Well, we don't have time to dive into every single one, but I do encourage our listeners to check them out. They're all free access, which is nice, so that you can click into them. And there are still 2 pending as well, so keep an eye out as these come to completion and publication. But before we dive into the ones that I've handpicked out a few of my favorites that I definitely want to spend some time on, but given your editorial role, we're going to give you right of first refusal. But I am curious, are there any surprises that emerged in the drafting or the consensus process, or any areas where you felt, oh, wow, the evidence is way weaker than I expected, or there's way too much variation in practice? We'll let you talk about anything that jumped out during this process to you.
Yeah. Well, I think when I went into this, there were probably some topics that I thought we would have a little bit more robust evidence to support what we're doing. So sometimes it was surprising to look back and realize this was just kind of a back of napkin. This seems like a good idea. Let's just throw it against the wall and see how it sticks. And lots of stuff didn't really have really solid evidence. Like if we were to start some of these practices today based on the evidence that was available when we started these things 10, 15, 20, 30 years ago, we absolutely would not start some of these practices. And yet we did start these practices a long time ago, and then these practices became quickly standard of care, air quotes, again, without a lot of evidence backing them. And many of these practices became very dogmatic. And it's like, well, this is the way we've always done it. This is the expectation of why we do things. To me, the fun part of this project was to actually then go back and look at like, well, wait a minute. I know this is the way we've always done it, but why are we doing it this way? And it was always started based on somebody recognizing a problem and wanting to make things better. So all of the things that we do were based on an altruistic intent. But sometimes when you're hoping for a solution, you believe in it more than you should. And you start to push other people to adopt it more quickly than we should. I was just lecturing at the EMS World Expo at the World Trauma Symposium and got to kick off that lecture series. And that was kind of one of my main points in the 20 minutes I had, was talking about change management. And if you look up change curve, you'll see that on the left side, you've got the innovators and early adopters. And then it's a normal distribution type of curve. So in the middle, you've got the bulk of people who are adopting stuff. And then on the far right side, it's the skeptics, the people that aren't going to start doing something new or change something unless you drag them kicking and screaming and force them at the pointy end of a stick. Um, but there's this gap, or called the chasm, between the innovators and the bulk of that middle part of the curve. And that happens in just regular industry and the regular market. You've got a new iPhone that's coming out. At what point are the people who are buying that and beta testing it and playing around with it and trying to break it and having fun with that? How much evidence does the market need? And we are the market. How much evidence do we need before we decide, okay, we're moving this out of the innovation or the investigation phase and into something that we should actually be implementing more broadly in clinical practice? So that to me was one of the things that resonated through almost every single one of these papers. Was we jumped that gap very prematurely um, years ago, and in reviewing the more evidence that's come along since that time, that's some of the big take-home message from a lot of these different individual papers, is that some of the things that we've been doing we should consider stopping. Some of the things that we're doing, we should maybe keep doing, but we need to look more closely at it, and we might get more evidence to tell us, hey, we should stop this. With a few exclusions, with a few exceptions, did we find anything that was like, yep, we were right back then, we're still right now, and we're just going to keep charging ahead?
Yeah, that's so rare, right? And I think that is a key piece to all of this. Is the best gift we can have is the ability to critically evaluate the research, because one thing I'm certain of is it's going to continue to change. And I feel like a lot of times that can be a frustrating experience. I mean, during COVID, we saw that in the public, how fast the guidance was changing and how frustrated people would become because they wanted the answer and they wanted it to not change. But that's really not how science works. We're going to test something, gather more data, and it is going to change, but we have to
Right.
be willing to review it, right?
Yeah, we used to think the earth was flat. We used to treat syphilis with mercury. We used to use leeches for all sorts of things, and we
I'm
found
glad
out,
we don't do that one.
yeah, exactly. And well, leeches, that's a good example. Actually, leeches are actually helpful in microplastic surgery. Um,
Okay.
so there's uses for some of those things. And another really important thing that came out for me in the compendium, and especially in my paper, the paper that I led on tension pneumothorax management, is everybody, maybe not everybody, so many of us are looking for the single answer for what to do. What is the best way to manage the airway in a trauma patient? What is the best place for us to put in a needle if we're doing a needle thoracostomy for traumatic pneumothorax? And the answer is the best place to put it is based on the individual characteristics of the patient that is in front of you. So you might look at all sorts of different pneumothorax papers that say, well, you should abandon the anterior approach and only go with the lateral approach. But if you look at the rest of the literature, you'll see that if you use the left lower lateral approach, you're going to spear the heart or the spleen and cause significant iatrogenic injuries. So on the left side, it might still be better to go anterior. If you're a really obese patient, sometimes it's better to go laterally, sometimes it's better to go anteriorly. If you're a pregnant patient, everything is displaced superiorly by everything that's going on below the diaphragm. So if you go with the left lateral approach, you need to move up a couple of interspaces. So again, you don't spear things you don't intend to. It was actually shocking to me reviewing the pneumothorax literature that up to 90% of the needles we put in don't actually get in the pleural space. I mean, that was one example of an extreme article, but even the ones that say 15 to 20% of the needles don't get where they're supposed to be was pretty shocking. It was balanced a little bit by the fact that up to 40% of the needles that we put in, patients never actually had a pneumothorax in the first place. So I guess if we're putting a needle in and it's not going where it's supposed to go on a patient that never needed a needle in the first place, then we net out in terms of not really harming the patient except for a little needle poke. But if we put that needle in a patient that didn't need to be needled and we spear the heart or another organ, that's bad. Um, so again, the take home message there is, as much as we want to figure out what's the one thing we can do for every single one of our trauma patients, um, the one thing to me is you individualize the care for the patient that's in front of you.
Absolutely. Make that shared critical decision making and be able to customize on the fly. I think that's really important.
Right.
Now, I'm going to dive into a couple of the areas here. I'm also going to invite our other panelists at this time to jump in with questions that they may have, but there are a couple of papers that I want to spend a little bit of time on, knowing that we can't possibly do all of them today. But one that has a lot of people talking and care is changing rapidly is this concept of fluid resuscitation with blood products, right? So this is an area where science has evolved rapidly. I know that I like to start off with the evolution and have some Pokemon. And, we started off with Charmander over here, and that was I don't know, like a bowl of pasta water. We were just putting saline in people and running it till they went pink. Then we got the next Pokemon up, and we had permissive hypotension was an okay thing to do, perhaps. But now we've got blood products. There's Charizard, right? So I want to talk a little bit about some of the guidance and some of the barriers and things that you found with regards to the pre-hospital transfusion of blood products.
Yeah. Well, so we looked at this as a question of actually a three-point question here on what do we do for volume resuscitation or resuscitation of the hypotensive trauma patient. So we've got one paper on blood products. We've got another paper on IV fluids, whether it's crystalloids, colloids, and then we actually had a third paper on use of vasopressors. So the three different things that some of us have available to us in the field to help manage the hypotensive trauma patient. And it was important to look at all three of those things because not everybody has blood. Even if blood is the best thing that we should be doing, and I'm not certain that it quite is yet, but even if it was, we still don't have blood available everywhere. It's a resource, it's a very limited resource. So there are some places where the only thing that the EMS clinicians can do is consider administering some IV fluids. Most of the time that's going to be crystalloid like lactated ringers or saline. If we look at that paper a little bit, that was one of the first papers we've published in the compendium. And that was led by one of our colleagues down in Cincinnati, Jason.
McMullen.
Yes, McMullen. Thank you. Sorry, his last name evaporated on me a second. And so we looked at that paper in terms of if you don't have blood, should we be giving crystalloid or whatever else? And the answer there is yes, some crystalloid is reasonable to administer. Large volume resuscitation with pasta water, which personally I think is a little bit of an inflammatory phrase. I get it's catchy, it gets people's attention, but I think it downplays the importance of some crystalloid is actually useful and important. You mentioned therapeutic permissive hypotension. That's a reasonable approach unless you've got a traumatic brain injury. So Dan Spate and a lot of our colleagues down in Arizona with their EPIC trials down there have really looked hard at this. And permissive hypotension for patients with a traumatic brain injury worsens outcomes. So we need to do something to try to restore circulating volume and get good perfusing pressure. So then we looked at the vasopressor side of things, and not a lot of evidence out there on that. But the take homes from that was actually vasopressors probably cause more harm than good. And if we think through that, yeah, vasopressors work by vasoconstricting, and we probably don't want to vasoconstrict things like the brain in those situations. So, but then, okay, let's get back to the blood products aspect. As you said, this is an area of pre-hospital research that is rapidly growing. And I think this paper was published about almost exactly a year ago already. So in some sense, this paper might be a little bit stale based on a bunch of the research that's been published since then. And that's okay because this was able to look pretty comprehensively at the literature that existed up until early 2024. And in this paper, we found that blood products are probably more preferred over crystalloids for first-line treatment of patients with life-threatening bleeding. Of course, the first thing we need to do is stop the bleeding if we can. It's important to restore volume with things that can carry oxygen, and saline and lactated ringers don't do that. But the pre-hospital blood research, if you look at most of the papers that were reviewed for this compendium document, They were still somewhat small studies. Some of them were biased in the patient selection. A lot of them were based on the military, where arguably the mechanisms of injury is different from the mechanisms of injury that we're experiencing in the civilian setting. Military is very high energy ballistic, um, blunt and penetrating trauma. Um, Civilian is some high energy blunt trauma from motor vehicle collisions. There's definitely our knife and gun club stuff, but it's not exactly the same as what's happening on the battlefield. And the system of care that's set up in the military is different from what we have in the pre-hospital civilian setting as well. As much as we want to be able to take things like TCCC and say, well, we've done this in the battlefield, let's just take TCCC and dump it on the civilian setting, it doesn't necessarily translate quite that well. So that's why we evolved that into TECC. Um, so in my mind, we are still over on that left-hand side of what I called the change curve earlier, where we still have lots of individual sites that are doing what I would consider trial studies. We know that resuscitating with blood in the emergency department works, and we want it to work in the pre-hospital setting. And it would make sense to us. The logic, we want the logic to make sense that if you're bleeding, the earlier we give you blood back, the better you should do. Um, but when you have a whole bunch of small studies, and Remley, you're much more articulate with describing how small studies can be much more subject to selection bias and all of the other things that interfere with whether or not their outcome is valid or not. So if you have a bunch of small studies with findings that are maybe questionable because of bias and you dump them into one bucket to try to make one giant bucket of evidence, doesn't necessarily make the evidence any cleaner. So to me, we're still in this early phase of collecting more information. Lots of areas are still investigating how we're impacting outcomes. They're doing good work with that, and the preliminary evidence from those sites is that blood products do seem to be improving outcomes. Um, I'm personally just a little bit skeptical that we've got enough information for us to jump that gap to say that blood should be used in every single ambulance and in every single helicopter. There are logistic reasons for that too. There are significant logistic limitations to being able to accomplish that. And not the least of which is we don't have that much blood available. And if we're putting it in the pre-hospital setting and it's not getting used or not getting used appropriately, or our patient selection isn't good and we're just giving the blood to anybody, we're using a resource and taking it away from other people that do need it. So that was kind of a stream of consciousness in there, I guess, which probably reflects the state of the science today.
Well, I couldn't agree more. And I really like this position statement for a number of reasons. And you highlighted all of them, actually. One being that this illustrates the complexity in pre-hospital care, in that this is related to several other statements within the compendium. And this is also why having a compendium is so important. So we can have the state of the science on those things that are interrelated and take into account locally available resources. Another thing I really like about this one is that it's not just focused on the clinical care. The clinical care is, of course, of utmost importance, but we also need to take the system into consideration. And so for me, the bullet points around making sure that we are recycling unused blood product in a manner in which it will be used, so not a single drop of blood gets wasted, is really key to ensuring the success of these, because working with blood banks, they are not going to be happy working with pre-hospital setting if we're returning expired blood, right?
Right.
And having the collaboration, all of the collaboration that's involved in one of these programs is extremely complex. So, I mean, I appreciate the efforts out there by the programs who are doing this, because they're publishing the barriers and the facilitators and the things that are going well and the things that they wish they could do different. So that I also hope that we don't jump the curve, so to speak, but that we build it by having the influence from these diverse systems, publish what they're seeing.
Right. And I guess I want to be clear so that I don't start getting hate mail that Dr. Ling says blood is horrible. I am in favor of using pre-hospital blood in the right setting. I'm in favor of continued investigation into how we can best use the resource. I'm just personally not quite convinced that we have sufficient body of evidence to help us jump that gap towards widespread adoption. And I think that to me, that comes from some of my own personal bias that I've developed by editing this whole trauma compendium and seeing all these instances in the past where we started a new practice based on just a little bit of evidence because we wanted it to work. And then we find out down the line, once it becomes ingrained, that, oh, wait, maybe we shouldn't be doing what we thought was good. Um, so it would be really unfortunate if we put a lot of resources into moving blood into the pre-hospital setting and find that it ends up having a neutral effect. Now, the evidence out there right now is suggesting that it's not neutral, that it's beneficial. Um, but again, I'm not sure that I am quite convinced to the point where I would be personally a champion of widespread adoption yet, but I'm willing to be convinced.
Well, I love the yet, right? That's how we should be as consumers of the research, is be able to think critically about it and weigh what's out there. And I think this is an area where my message for everyone on this one is to stay tuned and stay in touch with the literature. Weigh it. I think what John mentioned earlier on was important about the diversity of the small settings. While it might be internally valid and apply in that setting, it's important to think about, well, what characteristics were unique in that case that may not generalize as well to other settings. And so this is an area where we should be ready to adapt and ready to continue consuming the evidence as it comes out.
For sure.
I would add in just one part that I really liked about this one was we talk about having a system of care that is standardized and that has some indications and some reasons to give blood. Table 1 in this article actually describes that. So I thought it was really helpful to give some true diagnostics. It's not just we show up on scene, we see a lot of blood, and thus we're going to hang the ONEG. We actually got some systolic blood pressure, some shock index recommendations, even some lactate recommendations. And I think if I were the service provider that's looking at updating our clinical guidance to make sure it's the most robust, it's not just we're going to give blood when we see a whole lot of blood. We really do need some clinical parameters around it. And I appreciate that the authors took the time to go through the literature to say these are the ones where we think there's actual indications, things like major traumatic amputation with significant blood loss, penetrating injury, and even having a positive fast ultrasound. So I think those are some of the clinical takeaways that I would be looking at if I was a EMS service director, saying how can we update our protocols? How can we implement a whole blood program besides all the logistics that's necessary for that?
Right. Another thing that occurs to me is that in EMS, we all like Swiss Army knives. We like to we like to have a tool that we can then apply to other things. So one of the concerns that I have a little bit with some of the transfusion programs is scope creep. So some organizations or agencies are like, hey, a lot of other people have been doing this and they seem like they've been getting good evidence. So we're going to adopt it too, but we're not just going to do it for trauma patients. We're going to do it for patients with GI bleeding, and we're going to do it with patients with postpartum hemorrhage. And having this scope creep where, if we think the evidence in support of pre-hospital blood for trauma is relatively limited, it's even more limited for GI bleed and extremely limited on the postpartum hemorrhage aspect of things. And on the GI bleed end of things, there's a study, I can't remember the citation, from the New England Journal of Medicine a few years ago that looked at resuscitation of GI bleeding patients with blood and found that it could actually be harmful if you prematurely resuscitate some of those patients because you're popping the clot and things like that. And when I'm working in the emergency department, our threshold for transfusing those patients is a hemoglobin of 6 to 7. If you've got a hemoglobin better than 7, we're not transfusing you right away, even if your vital signs aren't great, which is a little bit of a mind-blown part of thing. Like your vital signs aren't great. They're losing blood in front of you. There's some context to consider. If you're actually barfing out bright red blood in front of me, I'm putting that blood back in as fast as I can, right? But if you're a slow GI bleed because you've got melanotic stools, because you've got a slowly bleeding ulcer, being really aggressive with resuscitating those patients can actually cause harm. And how do we determine that in the field? Most of us don't have a way to analyze hemoglobin in the field to drive those decisions if we're going to transfuse a GI bleed or not. So it's that scope creep of we've got this tool, we want to turn it into a Swiss Army knife. Again, altruistic intentions. But it's important for us to use that clinical resource that's very limited in a responsible manner.
Absolutely. I think that's a great call out too, that while this is the trauma compendium, there's certainly implications to other parts, right?
You know, one thing that you guys have touched on that I think is really important to point out in all these papers is we looked at clinical aspects of stuff with all the papers, but we also looked at implementation guidance. What changes need to be made at the agency or system level in order to implement the guidance that we're recommending. So whether that's we always included some type of bullet and resource discussion about what's the evidence in terms of the education we needed to be provided or the educational gaps, at the very least, identifying those. What are the financial aspects that we need to consider? What are the opportunity costs if we're spending time, personnel, money, and supplies on doing this thing over here? That means we can't, those are all finite resources that we can't spend on doing this thing over here. So there's opportunity cost to the things that we decide to do or not to do. And we tried to touch on all of those aspects of education, implementation, and quality management to make sure that we're doing the right things in each one of these papers.
Oh, you're speaking to my heart. Quality management. That is a space that I absolutely love. And thinking about how we apply improvement science and implementation science to these is really key for services who are looking to potentially make a change. Now, I know we're low on time, but I do want to hit at least one more paper because I think it's important for us to learn how to read these in context and not have knee-jerk reactions. You know, the AHA new guidelines just came out, and I've heard all kinds of things. And having been on a writing group, I was like, wow, I didn't know all this happened. But you know, well, we've got to take our Lucas device and throw it in the dumpster because AHA said so. Well, that's not exactly what the guidance says. And so I want to have that kind of a conversation here on what we are and what we may not be seeing yet. On one of the papers, I think it's probably one of the most downloaded papers of all times, we're going to talk spinal injuries. So I know there have been quite a few social media posts about this one, and I've seen graveyards and all kinds of things of like, let's just throw our C-collar in the dumpster. But perhaps you can give us high-level summary and then highlight, you know, some of the gaps that we saw in this as well.
Sure. So this is the third or fourth iteration of this joint position statement, or this joint topic amongst the alphabet soup of organizations. And the reason this one came up to be rewritten or reviewed is because the last version is over 5 years old. And with that, at NAEMSP, we have a goal that we're working towards of any of the guidance that we've given in the past. If it's more than 5 years old, we need to review it to see if it's still relevant or if we should retire it or if we should actually rescind it. There's papers out there on mask pants that we probably should just say, no, 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 don't do that anymore. So anyway, this one hit the 5-year review mark, which is why we started to dive into the evidence again. This swing at the ball, I would say, is the most robust review of available evidence that has been performed out of any of the previous papers. The previous papers were all consensus-based. There was some discussion of the evidence, but I would say that there was probably some selection bias in terms of summarizing evidence that supported what they wanted to say. They kind of did things backwards. They came together as a group and said, what are the things we believe? And pulled those bullets together in a position statement, and then went and found the resources to support those bullets. And that doesn't mean that there wasn't evidence to support those bullets, but then there was this giant gap of, wait, what about the evidence that actually says those bullets are wrong? So this paper worked really hard, and I credit Michael Millen and his co-authors for being as robust as possible with the resources we have. Now, could this have been a full-on grade methodology type paper? Possibly, if we had the right financial resources to do it. So Remley, you can maybe help people understand a little bit more what this whole grade methodology is, but it requires a lot of work, a lot of resources, and a lot of money to actually pull that type of review off.
Right. So that's the difference here. And I'm glad that you highlighted systematic review with a grading of the evidence, whether it's the grade tool or another tool, is a really resource intensive process that takes full teams and lots of work to not just collate all of the evidence on a given topic, but to apply a rubric to grading what are the likelihoods of bias that are at play here and how much stake should we put in this. And then those kinds of reviews also determine whether or not we can combine the data into what's called a meta-analysis. And so in this case, the authors are not grading the evidence, but they are pulling together a comprehensive structured review that was undertaken in a systematic way where all of the data on a topic got pulled together, but not going through that process of rating every single paper, and certainly not a meta-analysis, as I think John will highlight. These studies are from such diverse settings and there's so much heterogeneity, combining them into a single study wouldn't make a lot of sense.
Right. I think about, so I had the privilege of working with Dr. Jarvis on, and I think Remley, you were on the airway evidence-based guideline as well. And so that was another great paper. We did use grade methodology for that. And as much as we wanted to make more definitive recommendations, we had to stay true to the grade methodology and basically had to say, there's too much heterogeneity. We have to make neutral recommendations on, is BVM better than supraglottic, better than intratracheal intubation, and they had to make relatively neutral recommendations. Though we didn't do the full-on grade methodology with the spine paper, my experience with working on some of the other grade type projects that I've been on is if we had applied grade, we probably would have come up with, again, very heterogeneous, neutral recommendations. But that isn't always helpful to the person who's in the ditch in the dark with the patient. And we need to come up with something that's realistic to apply to the field. So in this particular paper, this one ended up being a systematic review, not a position paper with bullet recommendations. We started with it that way. But as you can imagine, this is a controversial topic, and trying to build consensus across an alphabet soup of organizations was pretty hard. We haven't given up on that. My understanding is we still have some efforts to work towards some consensus building and to come up with some bulleted recommendations. But in the interest of getting this included as part of the trauma compendium, we felt that this body of work in this systematic review was very solid. Even people or organizations that weren't yet ready to make or commit to some changes in how we're managing potential spinal injury in the field, even if they were skeptical of making recommendations to, air quotes, get rid of C-collars, they were still very complimentary of the research that this team did and their distillation of the evidence. So what are, this is a good example of, it seemed like a good idea at the time. The initial practices using spine boards was to be used as a extrication tool. There's a small town up in northern Wisconsin called Minocqua, Wisconsin. That's where the first published review of using a well-waxed piece of plywood to help extricate people from a motor vehicle crash. That was the first published paper on this topic, and from there it grew to, well, we've got the patient on the board. We think that if their spine is moving around a lot and they've had a spinal cord injury, that more motion is going to harm them more. So quickly we cemented the idea that we should reduce motion of the spine as much as possible in order to prevent secondary injury. What this systematic review finds is that there really was never robust investigation in terms of, is the thing we're concerned about real? In terms of, is the mechanism that we think is happening a real thing? And the authors in our paper offer an alternative hypothesis that it's not motion of the spine, it's actual hypoperfusion of portions of the spine that could be leading to the secondary paralysis and delayed spinal cord injury symptoms. We've found papers that showed that there is evidence of harm from being put on a hard board, and that there is evidence of harm from being put in a cervical collar. And I would challenge anybody who's been doing EMS for more than a few months to not come up with a story where they saw a patient where the cervical collar was put on backwards, upside down, sideways, or just the in general concept of cervical collars not fitting the patient well. I've seen them up over the lips, I've seen them over the nose, I've seen them in all sorts of different places that they shouldn't be. Meanwhile, I see those patients often trying to do, they're like Stevie Wonder, bopping their head all over the place because the collar is so uncomfortable. And then we take the collar off or switch it for something that fits better in the hospital, and they move their head around much less. We know that there's evidence that cervical collars can interfere with patency of your airway, that some of them, that there's evidence that it can interfere with cerebral blood flow in certain circumstances. So in some sense, we're trying to fit a square peg in a round hole, and saying that C collars are good for everybody. And it turns out the evidence suggests that C collars are bad for some patients. Um, but has been pointed out as we've been working on this paper for a year and a half. Um, let's see, how's the phrase? I might get this backwards, so correct me if I get it backwards, Remley. Absence of evidence is not the same thing as evidence of absence.
That's right.
Right? And Remley, why don't you, I'm going to tee that one up for you to maybe,
It's my favorite mantra.
yeah,
And I think it's an important phrase, right? And what it really is saying is that just because we don't have enough evidence on a topic, or there isn't evidence that something is doing good, doesn't mean you can't just take that as, well, it must be doing bad then. The converse is not necessarily true. However, in this case, we do see certain evidences of harms for certain patients, especially when we see poor fitting C collars or improperly applied. But I think the key thing here for me is, over all of these decades that we've been doing this practice, how very few studies were found. And then when we do look at the individual studies themselves, they're oftentimes small with a high risk of bias. So I would, for me, this is a big, we don't have enough data yet. And this is a great call out. And I'm glad that this compendium exists, because it tells us this is an area where pre-hospital research should certainly focus. And you think, okay, well, then we should just do it, just do an RCT. I think one of the challenges here, and John, you can back me up because you're one of the folks in the emergency department who would see this, is this is a really rare event. And it's hard to do RCTs on events that are extraordinarily rare. A new onset deficit with a spinal cord injury during EMS care would be a fairly rare event. And so it's hard to randomize that. We'd have to enroll millions of patients likely to be able to have what we call statistical significance, right? So this is an area where we need further study, but it's easier said than done.
right. I look at this paper a little bit like a stool with multiple legs. And so we have one leg of evidence that says some of these practices have risk that goes with them of causing harm in certain patients. So one leg that provides good evidence of risk of harm. The leg of what is the benefit hasn't been built yet. Okay. And a leg of, is there no benefit? I think we've got a little bit of evidence on that end of things. So spinal motion restriction or spinal immobilization, whatever group of words you want to use to describe it. A few years ago, we significantly reduced the use of long spine boards in multiple areas of the country. In some places, we did that successfully, and pre-educated the trauma surgeons and emergency departments and let them know we were making this change so that they at least would be aware of it. We had a really strong effort to do that here in Minnesota, and I did not hear a whole lot of complaints or heartburn or paramedics and EMTs being chewed out in the hallway by an ER doc or a trauma surgeon. In other parts of the country, I know that there were people that got chewed out in the hallways because they didn't bring the patient down on a board. That's not the fault of the EMS clinician. That's the fault of the system and the agencies in not helping get the stakeholders involved early and managing the change so that people understood why the change was happening. So since then, there have been a bunch of studies that have been done. I can't cite them off the top of my head, but studies that have looked at, okay, so did our reduction in use of long spine boards, is that causing harm to patients? And the results of those studies tell us that it's actually changing our practice and reducing use of long spine boards has not resulted in a bunch of quadriplegic patients. Um, There are definitely people who are convinced enough by the evidence of harm and the lack of evidence of benefit that they're thinking, okay, I know this thing can cause harm. We don't have any evidence that it does what we think it does. I'm going to change practice in my local agency and I'm going to get rid of C-collars. And that's where those tombstone type of attention grabbing memes originate from. And I appreciate those memes because they bring attention to an issue. And, even the memes about mechanical CPR and the AHA is going to pry those out of our cold, dead hands. Um, the memes are useful when they get people's attention and trigger them to look more closely at the actual document that was published and carefully read through it so they understand what the recommendation is. Not to hang up on the mechanical CPR end of things, but the recommendation was never that we should get rid of mechanical CPR in the field. In fact, it specifically said mechanical CPR might be useful in certain select circumstances. In our Minneapolis area, if we didn't have mechanical CPR devices on our ground units, we would not be getting our patients to Demetrius Yiannopoulos to ECMO and having the outcomes that we have. We know that if we were doing manual CPR with somebody hanging onto the railing on the top of the ambulance in a very unsafe way, trying to do very ineffective CPR, we wouldn't be getting the results that we get from our ECMO program in Minneapolis. So mechanical CPR is actually critical to that. So in that sidebar, back to spinal injuries, there are definitely physician medical directors who are very much on board with making the change. They want to be early on the change curve. They are convinced that they feel that there's sufficient evidence of harm and sufficient lack of evidence of benefit that it's time for us to change. There are going to be plenty of people who are on the other end of the change curve that say, we don't think there's enough evidence for us to really affect change yet, but we're going to keep a close eye on the guys and gals that did do the change and see what their outcomes are like. I'd venture to say that if at some point we find that the people that did affect change find that they're not having a lot of bad outcomes, that more of us will be convinced enough to say, okay, down in Florida, Ben Abo and his crews, they stopped using C-collars a couple years ago, and they haven't had any bad outcomes. Ben's a pretty smart guy. I think we'll do what Ben does.
Yep. It'll definitely be another area for us to continue to watch the evidence on. And now I know this has been a fabulous discussion. I have a brutal task of keeping us on track, but I see Michael Caduce wants to ask a question, so I'll let you ask second to last question.
I'll just bring in the summary, which is I think everyone should read this because it really does clearly articulate the research. And I guess my question was, we had the 2018 guidance that said, no C-collars or long backboarding and penetrating trauma, focus on blunt trauma. What do you think the takeaway from this article is? We sort of had the algorithm in 2018 that said these are the patients that should get SMR. You should sort of stop using your backboards, but they're equivalent to these other devices. Is this positioned for the clinical provider taking it to the next level or supporting that guidance from 2018?
Yes and no, and it depends. So I would say that if we had had the opportunity to actually put together the position statement recommendations for this document, we would have definitely reinforced the idea that C-collars and penetrating trauma don't bother. It's not a good thing. It doesn't help the patients. As to some of the rest of the document, the 2018 paper, I think that some of that recommendations are still relatively sound. But I do want people to stay tuned over the next few months because we are actively working with the other alphabet soup to come up with the bulleted recommendations that's going to be built pretty strongly on the systematic review paper. So there might be some additional course corrections on on use of different spinal care devices from the 2018 paper. But for now, I think it's reasonable for people to reduce use of long spine boards whenever they can. Carefully make decisions on whether they're using C-collars and not using them in penetrating trauma, not forcing a patient's neck to fit the collar. The collar should fit the neck, not the other way around. And personally, I think it's reasonable to allow patients that are alert and conscious and able to self-splint their necks to let them self-splint their necks. And I think there's some evidence in this paper that supports that approach too.
Absolutely, and definitely an area that is going to continue to evolve, and so stay tuned. Now, I have the tragic task of wrapping us up because there's so much good stuff here. We should have done at least 2 or 3 podcasts on this, and I hope that there will be more as the compendium is out and everybody gets to read some of these articles. But I always allow the author to have last words. Do you have any key take-home message that you want to leave our audience with?
My key take-home messages are individualize the care to the patient that's in front of you, and be careful about looking for the one-size-fits-all type of answer. And also that it's important to challenge our thinking and to look at our current practices and look backwards and figure out what are our current practices predicated on. Is it sound evidence? And if not, what do we need to consider to either continue the practice or alter the practice? And I really appreciate all the work that all the co-authors put into this entire compendium to help provide some of that evidence and to stimulate some new questions that we need to look at in the next few years with additional research.
Those are fantastic take-homes. They match mine exactly. And I just want to say thank you for your leadership in creating this incredible resource that I hope that our audience will check out in depth, the ones that we were not able to explore. And huge kudos to the village that you assembled that made this possible. This is no small lift and definitely something that will affect pre-hospital care for years to come. So thank you for your work here, and thanks for sharing your time with us.
Absolutely. And just as a reminder, all of these are open access. They're not firewalled or paywalled.
Yep,
you can
free.
Yep, they're free. You can find them through Google Scholar by doing a quick search for Prehospital Trauma Compendium, and pretty much all of them should show up that way.
Yep, and if not, if you go to Prehospital Emergency Care, they definitely all show up there. Same thing, you can click on them for free, which is a huge benefit that these are not sitting behind an academic paywall. So again, thanks for making that happen. It's such an important contribution.
Yeah, thanks very much for having me today, Remley and team.
All right, well, as a reminder for our audience, the education version of the Research Journal Club podcast will be Friday, November 28th, and we'll be back here with the last clinical podcast of the year on December 8th. I want to thank all of those of you who are listening live, and thanks all of you who are listening later. We really appreciate you having these conversations with us, and I will see you all next time.
We hope you have enjoyed and learned from this PCRF Journal Club. Please share it with other interested EMS professionals. An archive of past journal clubs can be found at pcrfpodcasts.org. You can also find us on Facebook at PCRF at UCLA and on our website, prehospitalcare.org. A special thank you to our sponsors, Limmer Education, providing educational tools for success at every stage of your EMS journey, and ESO, dedicated to improving community health and safety through the power of data.